Good afternoon, everybody. Hope you are enjoying online classes, staying at home and enjoying with your family members. So, today the topic is carcinoma of cervix. This is one of the important topics, and the most common and preventable cancer in women is carcinoma cervix. 1 million women acquire carcinoma cervix every year. So ratio of carcinoma cervix and carcinoma breast is 3:1. If you get cancer cervix cases 3, and we get only 1 case of breast carcinoma. So this is the commonest carcinoma in females. Coming to the risk factors, the early sexual intercourse, early marriage, secondly, early age of first pregnancy, mostly teenage pregnancies, and too frequent births at least intervals, and low socioeconomic status, and having multiple sexual partners, and sexually transmitted diseases, and infection of HPV virus, human papilloma virus, 16 and 18, and herpes simplex virus, type 2, and HIV and chlamydia are one of the risk factors for carcinoma of the cervix. Then immunosuppressed stage of the patient, like HIV positive individuals, and husband whose previous wife died of cervical malignancy, and oral pills users and smoking habits. They are the risk factors in a woman causing carcinoma of the cervix. Coming to the other risk factors, the cervix is composed of columnar epithelium, which lines the endocervical canal, and squamous epithelium, which covers the exocervix. The point at which they meet is called the squamocolumnar junction. The columnar and the squamous epithelium, there's the division of the margin at which they meet is called squamocolumnar junction. The metaplasia advances from the original squamocolumnar junction inward toward the internal os and over columnar villi. This process established an area called the transformation zone. The transformation zone extends from the original squamocolumnar junction to the physiological active squamocolumnar junction. Coming to one of the causes of human papilloma virus, the HPV virus, most important factor, and HPV infected cells, they are called coilocytes. We can identify them with large cells, large nuclei, and perinuclear halo or vacuoles. High risk are the HPV virus 16, 18, 31, and 58 types. The lowest risk group are 6, 11, 42, and 43. 90% of the patients of carcinoma cervix are positive for HPV and DNA and detected by PCR. The human papilloma virus type 6 and 11 and of low potential anogenital warts, they cause anogenital warts, but the 31, 33, 35, 51, and 52 are intermediate risk, and they cause cervical intraepithelial neoplasia 1, 2, 3. And 16, 18, 45, and 46 are high risk, and they cause SIN 2 and 3 and invasive carcinoma. There are certain vaccines that to have a preventive measures. Vaccines for prevention of cervical cancer are quadrivalent and bivalent. The quadrivalent vaccine is Gardasil, and bivalent vaccine is Cervirax. And coming to the effective against HPV virus is 6, 11, 16, and 18. Because it's a trivalent vaccine, Gardasil has got good use. And the bivalent vaccine causes immunity against HPV virus 16 and 18. Schedules are 0 to 6 months is Gardasil, and the Cervix is 0, 1, and 6 months. Route is intramuscular, both are intramuscular. Protects against Carcinoma Cervix and genital warts, the Gardasil, because it's a quadrivalent vaccine. And the Cervix protects against Carcinoma Cervix only, whereas Gardasil protects about Carcinoma Cervix and genital warts. This is the difference between Gardasil and Cervix. The pathogenesis of SIN and invasive carcinoma is squamo-columnar junction. It starts and replacement of columnar epithelium because of the metaplasia of reserve cells and squamous epithelialization. They result in replacement of columnar epithelium. The initially immature unstable cells, they become pathologic metaplasia and well-differentiated squamous carcinoma. On the other side, carcinogen, this immature unstable cells with the effect of carcinogen, they'll become HPV, carcinogens like HPV, seminal fluid histones, and HSV, and unknown factors. Then they will lead to atypical metaplasia, leading to SIN and carcinoma in situ and invasive carcinoma. This is the pathogenesis of carcinoma of the cervix, and these are the coilocytosis cells which have got anisocytosis, anisonucleosis, and vacuoles at the cells. This the changes that takes place in the cervix are first initially dysplasia, then non-invasive carcinoma, then invasive carcinoma. This is how it spreads. Initially, it starts with dysplasia and metaplasia, then non-invasive carcinoma, then invasive carcinoma. Screening for SIN and cervical cancer. How to screen cervical intraepithelial neoplasia and cervical cancer. Cervical cytology screening is very, very important, and that is called Pap smear. Onset of screening from 21 years of age, and frequency of screening is every 3 years for women between 21 and 29 years of age. HPV co-testing every 5 years, or cytology alone every 3 years. Then this IR spatula will collect the cervical epithelium by means of IR spatula, and they will stain it. And the other one is dysplasia of various grades, mild, moderate, and severe dysplasias. Then the malignant cells. This is how we scrape with the IR. This is IR spatula. How you are going to scrape? We have to rotate this IR spatula by 360 degrees. That is Jale cytospeculum, it's called. Total length is 220 millimeters. And the cells are cells from the endocervix, cells from the transformation zone, and cells from the ectocervix. This is how the cells are seen, and visual inspection with acetic acid. Initially, we apply acetic acid, then we do Schiller's test, that is with Logos iodine, and colposcopy we have to do. Colposcopy is a primary technique for evaluation of an abnormal cervical cytology smear. It is an instrument that uses illuminated low-powered magnification to inspect cervix, vagina, vulva, or anal epithelium. This is the use of colposcope. And indications for colposcopy are abnormal cervical cytology, smear or HPV testing, and clinically abnormal or suspicious looking cervix and unexplained intermenstrual postcoital bleeding. In these cases, we would like to do colposcopy. And the vulvar or vaginal neoplasia and history of enterodathel stilbestrol exposure in utero. If we suspect that she is exposed to diethyl estrogen stilbestrol, ethyl stilbestrol, we have to do colposcopy. Diagnostic conization also we can do to diagnose carcinoma of the cervix. We can take punch biopsy also. Diagnostic conization is indicated if colposcopy is unsatisfactory, if the lesion extends into the cervical canal beyond the view afforded by colposcope, if there is dysplasia on the endocervical sampling, if there is significant discrepancy between the histologic diagnosis of the directed biopsy specimen and the cytological examination. If microinvasive carcinoma is suspected, we would like to do conization or called cone biopsy. With punch biopsy, with the help of punch forceps, we will take a punch from the cervix at squamocolumnar junction or at healthy and unhealthy place, at the junction of healthy and unhealthy place, and we can take 4-quadrant biopsy from 4 quadrants of the cervix. This is how we are stained with acetic acid, and this is the malignancy after staining. Diagnostic conization and treatment of precancerous lesions. How do you treat precancerous when there is dysplasia or metaplasia? When the report comes as precancerous lesion where we suspect, we do cryotherapy. This is freezing tissue using a metal cytoprobe that has been cooled by nitrous oxide or carbon dioxide gas circulating within the probe. Then effectiveness is 85%, and common adverse effects are slight cramping, watery discharge, risk of infection. This can be performed by non-physician in a single visit. Simple equipment advisable only when the affected area is small. No anesthesia is required for cryotherapy. So coming to the next way of treatment, loop electrosurgical excision procedure. This is called a loop electrosurgical excision procedure. Removal of the diseased area of the cervix using electrically heated wires. Sample is then further evaluated. Here, the effectiveness is 90 to 98%. Bleeding either immediately or later can occur. And this procedure is fast, 5 to 10 minutes, must be performed by a physician, complex procedure, and requires local anesthesia. Coming to the other modality of treatment is cold knife conization. This is removal of cone-shaped area from the cervix. This is 90% to 94%. The complications are bleeding, infection, cervical stenosis, cervical incompetence, and possibly decreased fertility. Requires anesthesia, hospitalization, and highly skilled staff. Recommended management of abnormal pap smear. Whenever we do pap smear, if there is an abnormality, pap smear result or severe inflammation, evaluate for infection, repeat pap smear, treat the infection, then repeat pap smear if inadequate. Then the other conditions, atypia and ascus. The ascus means atypical squamous cells of undifferentiated significance. This is, Asker says, atypical squamous cells of undifferentiated significance. In these cases, colposcopy, biopsy if indicated, follow up with pap smear every 6 months. So then the next category is low-grade squamous intraepithelial lesion, that is SIN1. Here we do colposcopy. To manage this is SIN1 is colposcopy, biopsy if indicated, follow with pap smear every 6 months, and consider repeat colposcopy annually. Here's the next one is high-grade squamous intraepithelial lesion, that is SIN2 or SIN3 or carcinoma in situ, colposcopy, biopsy, treat with loop excision or conization. Then comes the invasive carcinoma. The colposcopy with biopsy, conization treatment with surgery or radiation has to be given. The gross types of carcinoma are exophytic, that means in a growth form, friable growth, and ulcerative in the form of ulcer, and infiltrative. And 80% are ectocervical and 20% of them are endocervical. This is how the changes occur. This is the normal cervix, that's low-grade cervical intraepithelial neoplasia, high-grade cervical sin, and cancer. They are the various changes that take place in cervix. And if we diagnose in SIN1 or SIN2, it's very easy to treat the patient with carcinoma of the cervix. Then there is a growth arises from the cervix. There is an exophytic growth. These are the two ovaries. There is a uterus, there is a cervix. There is a huge growth from the cervix. Histopathology, most of the histology is squamous cell carcinoma. 90% of them are squamous cell carcinoma, either large keratinizing or small cell non-keratinizing or small cell type of squamous cell carcinoma. So most of the carcinoma cervix are of squamous cell carcinoma arising from squamous cell. The adenocarcinoma cervix is only 10%. Their squamous cell carcinoma is more amicable for surgery, whereas adenocarcinoma is more amicable for radiotherapy and chemotherapy. This is how there is a normal cervix, hyperplasia, then mild dysplasia, where the changes are hyperkeratosis and hypernucleosis, and carcinoma in situ with severe dysplasia, and cancer invasive carcinoma. These are the changes that take place from normal hyperplasia and mild dysplasia, then carcinoma in situ, then carcinoma, invasive carcinoma. This is how the disease progresses. If we diagnose early in hyperplasia stage or mild dysplasia stage or carcinoma in situ, the prognosis will be very good and the woman recovers without any complications. So these are the various histological pictures when we see under microscope. This is the stroma and dysmorphic cells and exocervix, and these are the carcinomatous cells arising from the squamous epithelium. There are the various histological pictures. These are the biopsies when pathologist examines. These are the pictures what they see. How does it spread? Carcinoma cervix. It may spread directly in continuation. Hi, Kumar. Kumar, why brother? Kumar, Kumar. Sorry for the interruption. And this is because of the mode of spread is direct extension and spread through lymphatics. Primary group of lymphatics are parametrial, internal iliac, obturator, external iliac, and sacral nodes. From there, the secondary group are common iliac, inguinal, and para-aortic. So, generally, in Verdim cystectomy, where we do radical hysterectomy, we mostly remove primary lymph nodes and certain group of common iliac nodes, but we don't go for para-aortic or inguinal nodes. This is how it spreads. The staging. How do we stage the carcinoma cervix? Stage 1A is microinvasive and stage 1B are invasive confined to the cervix, whereas stage 1B1 are clinically visible lesion less than 4 centimeters. Then grade 1B2 are clinically visible lesion more than 4 centimeters. Then 2A, tumor invades the upper vaginal third, but does not affect the lower vaginal third. And stage 2B is tumor invades the parametrium, but not the pelvic wall, neither the lower vaginal third. That is stage 2B. Then stage 3A, involvement of the lower vaginal third without affecting the pelvic wall. Stage 3B, pelvic wall involvement and hydronephrosis. So it will go to the pelvic wall, and when its pelvic wall is involved, there will be obstruction of the ureter and it will cause hydronephrosis. The stage 4A, tumor invades the bladder anteriorly and the rectum mucosa posteriorly. So stage 4B is distant metastasis. So when we examine the patient with carcinoma of the cervix, to stage the carcinoma, we have to do, besides the bimanual examination or the vaginal examination, we have to do the rectal examination also to rule out the involvement of the rectal mucosa. When the rectal mucosa is involved, that comes to stage 4A. So these are the various stages of carcinoma of the cervix, and how far and up to what stage it is feasible surgery, we should go through it. This is how the carcinoma, the staging. What I said, it is shown in the pictures, the various way of spread of carcinoma of the cervix and the staging of carcinoma of the cervix. The patient comes with the symptoms of irregular vaginal bleeding or intermenstrual bleeding and offensive vaginal discharge. Whenever there is secondary infection, the women comes with offensive vaginal discharge and pelvic pain. When the bladder says symptoms, and bowel symptoms when the cancer advances to stage 4 and the involvement of the bladder and rectum are there, they'll come with those symptoms. Examination. First, when the women comes, we have to take the history, how much Paris she is, what is the history, whether she has got multiple partners or repeated marriages or childhood marriage or number of children. All these things we have to gather in the history. Then coming to the examination, first we will do the speculum examination. By that we will be able to visualize the nature of growth, exophytic or ulcerated growth, versus the intracervical growth or extracervical growth. It is the growth into the cervical canal or exteriorly it is seen. And rectal examination also we have to do speculum examination, then bimanual examination. In bimanual examination, we'll be able to know the size of the uterus and antevertebrate or retrovertebrate, and there is involvement of the growth to the parametrium. If the parametrium is involved, how far the parametrium is involved, medial 2/3 or up to the lateral pelvic wall, and then the growth has extended to the vagina or it is limited to the cervix, we will be able to know by bimanual examination and speculum examination. Coming to the rectal examination, we will put in a finger into the rectum, we will feel the rectum whether the mucosa is adherent or free. If it is free, there is no, the mucosa is free, we can conclude that the rectum is not involved. Growth bleeds on touch and is quite friable and fixed and indurated. How to diagnose? Confirmed by punch biopsy. The differential diagnosis are the other conditions that can simulate carcinoma of the cervix are cervical tuberculosis, fibroid polyp, and syphilic ulcer, and products of conceptions. These are the various masses that are to be confused with carcinoma of the cervix. The complications are pain, sepsis, and pyometra. So because of the growth, the cervical canal may get obstructed and it may get infected and pus may get collected inside the uterus. That is called pyometra. And VVF, vesico-vaginal fistula. If the bladder is involved due to the growth, it may lead to vesico-vaginal fistula. Recto-vaginal fistula. If the growth involves the rectum, there may be a communication between the rectum and the vagina. The commonest cause of death is because of the ureteric obstruction due to the parametrial involvement. There may be uremia, that is the usual cause of death in carcinoma of the cervix. Before starting treatment, the preoperative or pre-treatment evaluation is physical examination, staging, blood investigation, liver function test, cystoscopy to exclude any bladder involvement, and IVP, intravenous pyelography, and correct anemia. Because generally the women with carcinoma cervix are low socio-economic group and they are mostly suffering from that. Because of the intermenstrual bleeding since long, they may be anemic. So you must correct the anemia. The treatments available are primary surgery, primary radiotherapy, combination therapy, and chemoradiation. So only surgery, primary radiotherapy, a combination of surgery and radiotherapy, or chemo and radiation. Surgery is called radical hysterectomy. Here we remove uterus, tubes, ovary, and a cuff of vagina, and parametrium, cardinal and uterosacral ligaments, and primary proof of lymph nodes. This is called Werthim's radical hysterectomy. There is another surgery called Mitras radical hysterectomy. Here we do the radical hysterectomy, opening the abdomen and peritoneum. Then extraperitoneal lymphadenectomy we do. Whereas in Werthim's hysterectomy we do internal lymphadenectomy, intraperitoneal lymphadenectomy, whereas in Mitras we do extraperitoneal lymphadenectomy. This is the only difference between the Werthim's and Mitras hysterectomy, Mitras radical hysterectomy. And advantage of surgery is thorough assessment. Ovaries can be preserved if the woman is young, and retention of viable vagina, which can have where the women can have intercourse by preserving the vagina, and psychological benefit also given by doing surgery. Complications of surgery: ureteric injuries, bladder dysfunction, lymphocyst formation can occur when we remove the lymph glands, and lymphadenectomy when we do, lymphocysts are likely to form. The other surgeries are exenteration. The exenteration is removal of, it may be anterior or posterior. In anterior exenteration, we remove the bladder, we keep the ureters into the bowels. The implantation of the ureters into the bowels. So the woman will be passing urine and motion through anus. That is called anterior exenteration. The posterior exenteration, where we remove the rectum and we form ileal conduct. That means we will attach a bag and we will create we'll let the rectum out, or we do colostrum. This will repose the intestine at the inguinal region and create an opening, and we'll keep a bag into which the feces gets collected. That is called posterior exenteration. At times there may be, if the spread of the carcinoma is both bladder and the rectum, we'll do total exenteration. And besides these open surgeries, we can do laparoscopic radical hysterectomy and laparoscopic lymphadenectomy also. The other modality of treatment is radiotherapy. The advantages are applicable for all stages of carcinoma. Good results, less morbidity and mortality. Radiotherapy are various types: brachytherapy, uterine tandems are kept, plus colpostats in both the vaginal, both the side vaginal pouches. We'll put this called brachytherapy. So by the side of the cervix, we keep colpostats to emit the radiation. And inside the uterus, we keep uterine tandems. Then this may be after-loading technique and remote control, or radium, cesium, and cobalt therapies. There are the various radiological methods of treating carcinoma cervix and packing the vagina with this colpostats. And the energy what we have to give is this 7,000 to 8,000 centigrades. This is cancerolytic radiation. 7,000 to 8,000 centigrades is cancerolytic radiation what we have to give to treat the carcinoma of the cervix. The brachytherapy, there are various points, point A and point B. Point E, where we have to give radiation, is 2 centimeters cephalic and 2 centimeters lateral to the external os. Point B is 2 centimeters cephalic and 5 centimeters lateral to the external os. The point gets 7,000 to 8,000 centigrades, and Point B gets 2000 centigrades. The supplemented by latter, they are supplemented by 4000 centigrades through external irradiation. This is how we give radiation to the patient with carcinoma of the cervix. This radiotherapy can be given at any stage of carcinoma of the cervix. The complications of when with the radiation is loss of ovarian function, loss of coital function, because the entire vagina gets stenosed and fistulae are likely, fibrosis of the bladder and bowel are likely. Management of carcinoma cervix stage by. So if it is a stage 1, A1, young patient, family not completed to retain uterus, therapeutic conization. Old patient, family is complete, simple extrafacial hysterectomy. In stage 1A2 and stage 1B and stage 2A, we either do radical version hysterectomy or Madras radical hysterectomy. Management of carcinoma cervix stage wise, that is stage 2B, stage 3 and stage 4. They are advanced carcinomas where concurrent chemotherapy, chemoradiation is advanced. We'll give chemotherapy and radiation both in stage 2B. So up to stage 2A, we can do surgeries. When it is advances to stage 2B, either stage 3 or stage 4, we have to resort for concurrent chemoradiation therapy. The stage 1, 2, stage 1B, stage 2A are radiosensitive and surgically operable, but surgery is preferred over radiation for these stages for the following reasons. So preservation of ovarian function, this we do in a patient who are young. By this, if the stages are 1A2, 1B and 2A, we can resort for surgical resections by doing radical virgins or Mithras surgeries. The advantage of these are preservation of ovarian function, preservation of vagina for coital function, and psychological benefit to the patient by doing surgeries. Thank you. So any questions you can put if you have got any doubt. Kumar. Any questions? from the subject what we have covered, carcinoma of the cervix. If you have got any doubts, you can ask questions.